Welcome to the self-evaluation episode of the ASCO University Weekly Podcast. My name is Wendy Vogel, and I'm an oncology nurse practitioner from East Tennessee and the president of APSHO, the Advanced Practitioner Society for Hematology and Oncology. Today, we feature a self-evaluation question on the correct chemotherapy dosing in an obese patient, and we begin by reading the question stem. A 50-year-old woman with morbid obesity, hypertension, hypercholesterolemia, and type 2 diabetes was recently diagnosed with breast cancer. She has a 3.5 primary tumor, which was invasive ductal adenocarcinoma, estrogen receptor negative and progesterone receptor negative, and HER2 amplified by fluorescent in situ hybridization. She had surgery, and 5 positive axillary lymph nodes were removed. On examination, she is obese with a body mass index of 36, height is 5 foot 7 inches, weight 230 pounds, but her vital signs are otherwise normal. Her surgical wound is well healed, and her cardiopulmonary examination is normal. She has no residual lymphadenopathy or edema of upper or lower extremities. You are recommending adjuvant chemotherapy. Which of the following statements is correct about her adjuvant treatment? A. She is not a candidate for dose-dense chemotherapy due to her morbid obesity. B. Treating her at ideal body weight will reduce the chances of permanent side effects without compromising her disease-free survival. C. You should cap her chemotherapy at a body surface area of 2.0. D. You should dose her at full dose despite her morbid obesity. The correct answer to this question is D. You should dose this patient at full dose despite her morbid obesity. ASCO has clinical guidelines for the correct dosing of chemotherapy agents in the obese adult with cancer. ASCO's clinical guideline recommends full weight-based chemotherapy doses, both IV and oral, that these be used in the treatment of the obese cancer patient, particularly when the goal of treatment is cure. Selecting reduced doses in this setting may result in poor disease-free survival and overall survivor rates. Briefly, the other choices presented in this question do not represent the most appropriate therapy for the following reasons. Answer B is incorrect because there is no evidence that short or long-term toxicity is increased among obese patients receiving full weight-based doses. Most data indicate that myelosuppression is the same or less pronounced among the obese than the non-obese who are administered full weight-based doses. Clinicians should respond to all treatment-related toxicities in obese patients in the same ways they do for non-obese patients. The presence of obesity alone should not alter clinical judgment. Answer C is also incorrect. In the past, many oncologists used either ideal body weight or adjusted ideal body weight or to cap the BSA at, for example, 2.0 meters squared rather than use actual body weight to calculate BSA. However, the data do not support this concept, and this practice could compromise outcomes. There are compelling data in patients with breast cancer that reduced intensity chemotherapy is associated with increased disease recurrence and mortality. Although data in other malignancies are more limited, based on improved survival observed with chemotherapy compared with controls, a dose-response relationship exists for many responsive malignancies. The ASCO guidelines recommend consideration of fixed dosing only with select cytotoxic agents, such as with carboplatin and bleomycin. On the basis primarily of neurotoxicity concerns, vincristine is capped at a maximum dose of 2.0 milligrams when used as part of the CHOP and CVP regimens. Several other cytotoxic chemotherapy agents have been used in clinical trials at a fixed dose independent of patient weight or BSA. However, it is not clear that fixed dosing is optimal for any of these other agents. It should be noted that this guideline does not address dosing for novel targeted agents. It should also be noted that this expert panel recommended that the BSA may be calculated using any of the standard formula. There is no evidence to support one formula for calculating BSA over another. It is important to reassure patients that toxicity from the appropriate dose of chemotherapy is not expected to be greater. Adverse events will be monitored closely. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on the treatment of cancers, including opportunities for self-evaluation, visit the Comprehensive e-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.